Welcome to the Turd Nerds. We are the functional gastroenterology podcast discussing all things poop. Before we take the plunge into today's episode, let us tell you a bit about ourselves. I'm Dr. Rebecca Sand, a naturopathic physician and acupuncturist, and I specialize in all things gastroenterology, hormones, and fertility.
I'm Dr. Ami Kapadia, and I'm a medical doctor trained in family medicine and functional medicine with a special interest in gastrointestinal health, food and environmental allergies, and autoimmune disease.
And I'm Dr. Ilana Gurevich, a naturopathic physician and acupuncturist who is board certified in naturopathic gastroenterology. I specialize in inflammatory bowel disease, IBS, and other functional digestive disorders. Let's jump into today's episode.
The following discussion is for educational purposes only and not intended to diagnose or treat any diseases or conditions. Please consult your doctor before incorporating any of this information into your care. The information presented on this podcast is not medical advice.
All right, everyone. We're back for another exciting episode of the Turd Nerds podcast. Today, we're going to have Dr. Gurevich lead us through a discussion of microscopic colitis.
Hi, everybody. So this is a condition that I actually kind of love to treat, mainly because oftentimes our naturopathic therapies respond really well, and frequent times the conventional therapies actually respond really well as well.
Yeah, it's steroids.
It's more to figuring out the diagnosis, I feel like. It's what's often missed.
It does often take a while to figure out the diagnosis, for sure. Okay, so
are we going to...
Go on.
I have so many
much
things
excitement.
I want to talk about here. We're going to go through testing options.
I mean, really, you have one test.
I know.
But when to consider testing, because this was not something that was tested for routinely until, recently. My older years.
Until they come to us and we're like, go back to your gastro, get a biopsy.
I've had GI reports testing more recently as well, like good. Compared to when I was a younger.
So why don't we actually start by explaining that? So when we send a patient for colonoscopy, they're going to fall into one of two tracks. One is going to be a screening colonoscopy. The other one is going to be a diagnostic colonoscopy. And this is honestly where microscopic colitis patients fall through the cracks first. Mm-hmm. So let me give you guys a really good example. I had a man who came in, he was probably middle 60s. This guy, if you're talking about somebody who has diarrhea, he had diarrhea for 20 years before he ever came to see me. He had a diagnosis of Lyme. He had a diagnosis of mold. He had a diagnosis of, dysbiosis, everything. IBS. He had, interestingly, never seen a gastro. Weird. And I'm listening to his case, and I'm listening to sometimes, 4 Bristol 7 bowel movements a day, sometimes 20.
Oh
and he had cap protections because he had seen other functional medicine doctors before. Right. Those are always negative.
Yep.
And that's a keynote. Microscopic colitis, the cap protection is negative.
Yep.
So I'm listening to his case, and I'm like,
that's weird though, isn't it? Because there is inflammation.
Mm-hmm. You're getting ahead. You're like, what my husband's always like, you dropped the punchline or something.
Yeah.
All right. I'm confused already.
Okay. So
and they're not usually as bloody.
There's no blood.
So they're not getting the attention from the gastros or from other people to go in and get scoped again.
Chronic, watery, non-bloody diarrhea. That is, when you are listening to that is what you're thinking.
Yep.
So your differential with these people is often parasitic infection, Giardia, acute, some kind of acute gastritis or gastroenteritis.
Yep.
And then if it's prolonged, microscopic colitis.
Totally.
So this guy comes in and he has been for 20 years been dealing with diarrhea. It's been kind of crazy. And he was sent to me by another naturopath who managed his hormones, but didn't really know what to do with his GI tract. And so I'm listening to him and I'm like, have you ever had a colonoscopy? And he was like, oh no, I'm not interested. And I was like, dude, I think what you have is microscopic colitis.
Get interested.
I want to that one was a pearl there. I just want to have you recap. So chronic watery diarrhea.
Non-bloody,
mm-hmm. Chronic watery diarrhea, generally infectious or microscopic colitis. There's not a whole lot.
As long as it's chronic,
right.
Prolonged.
If it's acute, there's various other infectious causes.
And of course, you can have both.
You can also have everything else that we always talk about.
Right.
Do you see mucus?
No.
No mucus either.
Not really.
Because there's not a ton of things that cause chronic watery stools is what we're saying.
I mean, it's generally infectious. It's something going on with the integrity and the functionality of the colonoscopy.
I've seen it not be watery though. I had a patient recently who, similar history. It wasn't watery. It was just on and off really loose, but would have up to 20 a day.
Bristol 6, Bristol 3,
yeah,
Bristol 5.
Kind of between soft serve and loose,
and
but
were they
not
taking
watery. Well, she self-diagnosed, and no one would give her steroids or anything to try to help, and she would have urgent, couldn't drop her kids off at school, would have to go in a bush, just miserable.
Yeah.
was in Mexico, got herself some steroids, got better.
So that is the thing. Okay, so this guy comes in and I am like, oh, 65 years old. I was like, you need to get scoped.
Yep.
You need to get scoped. And so we sent him to the gastro and he goes into the gastro explaining, I have this chronic diarrhea. What does the gastro do?
Not a biopsy?
Run a screening colonoscopy. So what's the difference, right?
Yep.
So when they go in for a screening colonoscopy, they're going pretty quick and they're looking for like a blatant polyp, right? They're looking for something that's atypical, that's sticking out. A polyp, some kind of ulcers,
it's a screening for
inflammation.
cancer
Because
only,
it's
really.
screening for cancer only. And this 65-year-old man is in the appropriate age group to screen for cancer.
Ugh.
They never took a biopsy.
But and what might have happened is he might have called and said, I need a colonoscopy. And often you just get the procedure. You don't even talk to a practitioner first.
I would believe that if I didn't actually have a conversation with him. And
That's
he,
insane.
before he went in for the anesthesia, he looked the gastro in the eye.
That's what I tell him to do too.
And said, well, this is diagnostic, right? Because
biopsy.
I wonder what happened.
Here's the other thing about it that's important to know. And this is where patients get ruffled. Like patients will come in and they need a colonoscopy and they're symptomatic. They're having blood in the stool or something. And then they get a bill for their colonoscopy because it becomes a diagnostic colonoscopy because they got to take a bunch of punches to diagnose.
Yep.
And then they're like, why am I getting this $5,000 bill?
Totally.
And the gastroenterologist is like, because I had to do a lot more work. It's not a screening. I'm not just looking for something to pop out at me.
Right.
So they totally missed it with him.
You think it's just because they're going from patient to patient and it's generally screening.
And I think the gastro's a human. Like,
yeah, we all make
world.
mistakes. Yeah.
Yeah, like it just, and it's just a bummer because this guy's not ever gonna, like, it took me like months to convince him. No.
It's
and
not
then
a fun day.
the other place where we end up missing these patients is, and I have a lot of these patients who live rurally where there is no gastroenterologist in the rural community.
Yeah.
So oftentimes what happens is they have to drive for a hospital system and surgeons will come in and moonlight and do the colonoscopies to moonlight. But the primary care is like, well, let's just give you a Cologuard. You know, like there's only one way to diagnose microscopic colitis.
Yep.
That is with a biopsy on a colonoscopy.
Yeah.
And it's even more complicated because when they're going in on the colonoscopy, it looks fine.
Yeah.
There is no inflammation that is noted, which is why, and then they take the biopsy and they find microscopic inflammation.
That's the microscopic.
That's the microscopic colitis.
Hence its name.
Yes.
But unusual that it causes no elevation of inflammatory markers.
Elevation at
even
all.
like HSCRP,
Nope.
ESR.
Nope.
Crazy.
Nope. There's no, I mean, it's a little bit annoying.
Yeah.
So okay, what do they do? Well, there are the treatment actually, and this is what I tell my patients, 70% of the time, budesonide, which is a localized larger steroid that still goes systemic, but only 15% of it, as opposed to, prednisone, which is like 100% of it goes systemic. Generally it works.
And it's rectal administration.
Nope.
It's oral administration. That's
oral,
right. It's
yeah.
the special delayed release oral.
That's exactly what it is.
From your lecture, I learned this.
Yeah, it has like a multi-matrix structure around it that keeps it intact until it hits the large bowel, and then it starts to slowly
Because you had
dissolve.
another patient that unfortunately the provider ordered the regular version and it didn't get better.
Yeah, it was an immediate release.
Okay, we're getting ahead of ourselves again.
Yeah, so that was another great patient. It's interesting because the cases that come out to mind actually are males, but generally women have a higher likelihood of developing microscopic colitis than males.
Huh, I didn't know that.
Yeah.
I thought it was males. I thought it was like males in their 30s.
Oh no, hold on.
Or isn't there like a double wave of it? Like teens and then 50s and 60s or something?
That's inflammatory bowel disease.
In general.
This is generally a larger disorder.
Which is not really under the overhang of inflammatory bowel disease or
No, it's kind of in the middle.
Yeah.
It's not a Frankie. The IBDs are UC, Crohn's, and celiac, right? This is kind of something that's like not IBS, but not IBD. There's anatomical changes happening, but you don't see it unless you biopsy.
Right.
But it is a colitis and it responds to steroids.
It responds to steroids.
Which IBS definitely does not.
So let's say we do a standard of care treatment. We generally will put them on the budesonide formulation that waits to dissolve into the large bowel. And that formulation will usually for about a month. And then we still taper them down. And it's very responsive to care. So the patient that Ami is thinking about this is a patient that was consulting with me. And mainly I was consulting with his primary care doc because she was like, what do I do with this person? And I was like, he needs a scope. And he was in rural America. He had to, she was like, I gave him a Cologuard. I was like, don't do it. It's not going to find anything. I don't think he has colorectal cancer. I think he has microscopic colitis. He went to see the surgeon. The surgeon did the colonoscopy. Turns out he had microscopic colitis. But she's a primary. She's not used to dealing with it. She's not specialized. And so I was like, this is the treatment protocol. And it's just the drug branded is very expensive, but you can compound it. It's been around forever. And so she sent it to the compounding pharmacy with an immediate release formulation. And then I'm listening and I'm like, why aren't you getting better? Like budesonide generally makes people better. Like what's wrong here?
Yeah.
And then we started digging and I was like, oh, you needed the sustained release.
Yeah.
We needed to wait. And then we had to redo it. Luckily it's way cheaper than branded. And then he started getting better. Yep.
You're never using rectal? Because it's spanning the whole...
Because it spans the whole colon. So let's just talk about rectal administration really fast. Let's say you have a suppository. Suppository is literally going to cover the size of the suppository. Like that's how much bandwidth is going to get covered.
And the foam isn't much farther.
Foam is like a little bit farther. So instead of like an inch, maybe you've got 3 to 5 inches.
It's pretty much proctitis. Yeah.
It's pretty much proctitis.
And isn't there a prescription enema type version as well?
So then you go enema, right? And enema's probably going to go up like halfway up the sigmoid colon. This is not ulcerative colitis.
Right.
Like it's generally
the whole colon.
Like you'll punch and you'll find microscopic colitis throughout the whole colon.
But it spares the small intestine?
Nothing on the small intestine.
Yeah.
Cool.
Yep.
Only
but
large
it's
bowel.
15% systemically absorbed.
15%
which
systemically
isn't horrible.
So what does that translate into? What are we worried about with that 15% systemic absorption?
Insomnia.
Okay, sure. Keep going. What else?
The systemic effects of steroids.
Bone loss.
Yeah.
Yeah. Immunosuppressive action of steroids. Blood sugars. Yeah. I mean, it's not a nothing.
Yeah.
But you're also not doing it forever.
But it's a very short course.
But when it's the only treatment and people are in and out of flares.
It's the only treatment in conventional medicine.
Tell us more.
Definitely. So I went through a period. I think it had to be before COVID. When I was like, I think the reason why I say I think it had to be before COVID is because I was at a conference and me and Eric Yarnell, who's a naturopath that we talked to, he's a pretty phenomenal herbalist. Me and Eric Yarnell were at the conference and I was like talking to everybody like, what are you doing? What do you know? How are you figuring out microscopic colitis? I asked a bunch of our colleagues and Eric Yarnell he said, parasites or food allergies. He was like parasites or food allergies. So what do I do?
Old favorites.
Right. Well, I mean, but he wasn't wrong.
Right.
So what do I do? The first thing I do is budesonide. Like, why torture them with a naturopathic protocol if budesonide's going to work? Like,
let's at least get the symptom improvement.
Right. Totally. That's kind of like where I'm at. Maybe it's going to be a one and done. Maybe we'll get lucky.
Maybe the immune system recovers enough, starts absorbing nutrients, and they take care of whatever the infection was without having to like go down the whole road.
So,
but yeast too, right?
Okay, you are.
I'm sorry.
Cart before the horse.
Yeast and steroids.
Yeah. So so
not
are
a
you
good mix?
Okay. So let's say you do budesonide, and what happens, which I think definitely happens for 30 to 40% of the time, is it just doesn't work, or it's not good enough, or they can't get off of it. Right? Like they go through their 1 month course. We try to taper. Everything's great. We try to taper 2 weeks after the tapering is done. All the symptoms are back.
Yep.
Like that. This is like, now we're starting to think microbiome. We're starting to think infection. And so at that point, what I will generally do is I will generally run a stool test.
Yep.
And you guys know how I feel about provoking.
Yep.
I like to provoke my stool tests. And so I'm looking for parasites, protozoa, worms, and like crazy fungus, biofilms. That's what I'm looking for.
Yeah.
And so that's the next thing I do. And then I kind of treat off of that map. And I will say that does probably get me another 20-25% of patients. And so one of the things that we'll try is, okay, are they parasites in there? Okay, great. There are, let's deal with the parasites. I usually use pharmaceuticals, and I'll usually go through a big biofilm thing, even with parasites. Okay, that clears a picture. Okay, that didn't do it. There were no parasites. Was there fungus? Okay, now we do our fungal protocols, and then we treat with the fungal protocols. Okay, that didn't do it.
And you're just going based off symptoms because there's nothing else we can use to track.
I'm just going over basic, and I think it's enough.
Yeah.
Because it's it's like 20 loose watery stools a day.
I mean, not always. Sometimes it's like 4 or 5.
Right.
Yeah.
But they can usually tell if something's helping or not.
Yes. I mean, and that's how you know budesonide is helping.
Yeah.
Because it's like.
And budesonide helps around what percentage of the time, do you think?
60 to 70.
Okay.
I do think, and budesonide works really, really well the first time you use it.
So conventionally, they just keep if it doesn't work,
that's a great question. So conventionally, first they start budesonide. If it doesn't work, then they start looking at the mesalamines, sulfasalazine, mesalamine. They start treating
Does
it like
mesalamine do anything?
For some people.
Wow.
And then if they can't get control, then they start looking at biologics.
Yikes.
Yeah, so they'll treat it very
So there's an
similar to an
autoimmune component.
They don't know.
Okay.
It's not clear.
Have you used mesalamine in these cases? Okay.
Yes.
Because you have quite a bit of experience from treating IBD.
And I just feel like
it's a pretty safe medicine, anti-inflammatory.
Also, a lot of these patients are tricky because they're doing so bad, but it takes them so long to get in for the colonoscopy.
Yeah.
And so then you're doing all of your treatments. And so oftentimes you'll kind of almost miss being able to see it. And I have one patient like that who was like the most complicated microscopic. She's had microscopic colitis for like 25 years. And we tried the budesonide. It would help like magic. And then, a decade later, it's not helping like magic anymore. And so then we jumped to the mesalamines and it would help like magic. And then it's not helping like magic anymore. And so now the gastro is pretty convinced she probably has Crohn's, but they just keep missing it.
Can you get Crohn's? Can you sort of progress into the more severe IBD?
I mean, I think that there is a little bit of it's a spectrum.
Yeah.
So I think it's not unheard of to get diagnosed with microscopic colitis first, and then 5 years, 10 years later, get diagnosed with ulcerative colitis or Crohn's.
Sounds autoimmune. But okay, go ahead. I have two questions.
If mesalamine helps, you could just keep them on that.
Yes.
Yeah.
If mesalamine is strong enough. Right. If mesalamine is strong enough.
Even while you're looking for other things if they eventually want to get off of it, it's a pretty safe thing.
I would agree. And I also have no concerns about pulling them on and off of it. I do have a small subset of patients that don't tolerate mesalamine, but generally a pretty small subset.
Okay.
And then, the other thing that I always worry about, or that's always in my thinking is, mesalamine, basically any of the drugs, they're coated in phthalates. Which is known to be more irritating to the intestinal, you know what I mean? And so then I'm like,
why do we do this?
Am I doing more harm than good? We do it because we need that multi-matrix covering to be able to dissolve in the right place.
Yeah.
But that's how we do it with phthalates.
I wonder if there's some compounded version of that.
I don't think I have ever actually compounded up mesalamine. That is a great question.
For our compounding pharmacist.
Yeah, I'll ask
our local compounding pharmacist.
I'm on a pretty close, intimate texting relationship with my compounding pharmacist.
That's right.
Can I tell you guys a funny story?
Yeah, but I have two questions.
Okay, go.
No, it's okay. Go funny.
So, I had my compounding pharmacist reach out to me because I do, I prescribe, I think more Biozol, like the biofilms that are
She's like, why does this make people feel so much better?
Well, she reached out to me and she was like, I have this doctor and this doctor put in this really kind of weird prescription, and I don't, the doctor's like, she doesn't really know what she's doing. She just kind of heard some biofilm episodes. Are you okay? And I was like, yeah, I'm happy to talk to anybody. Like, this is a prescription that I know pretty inside and out. And then 10 minutes later, I get off the phone with my compounding pharmacist, and one of my best girlfriends from school texts me, and she was like, I'm the doctor. I don't know anything. And I was like, oh, Pammy, I got you. It's very sweet. Okay. It's a very small community. The take home is it's a very small community.
I wonder if we prescribe more bismuth in the country than like anywhere else.
Okay, so talking about budesonide.
Yeah.
I have a patient who will fly in and see me. Very, very complicated. He has familial FAP. Basically, like he has a familial predisposition to forming polyps that are cancerous in his colon, right?
Yeah.
So he's colectomy. And he gets scoped. He used to literally run the foundation. He gets scoped very, very often. And they found what might be some inflammatory process that could be Crohn's. And I was like, let's do budesonide.
Yeah.
But we can't do the regular budesonide because you don't have a colon. We need it to go earlier. Mm-hmm. And so he was trying to get his prescription filled where he lives. And he was like, the compounding pharmacist there was like, I can't fill this because I would need to order, 200 pounds of budesonide because they're just not doing it there.
Yep.
Like what we do in the Pacific Northwest is like cutting edge, mind blowing. You know what I mean?
Super
like
cool.
It's really, it's like very cutting edge where we can really truly make precision medicine for our patients.
Yeah. And try to remove all the gross stuff
if
we can. So on bismuth, a family member of mine had a friend whose GI told him to take Pepto-Bismol 4 caps a day, every day for some kind of like symptom.
Probably diarrhea.
Maybe diarrhea. Years.
Yeah. Oh yeah.
Then he got some weird neurologic stuff like MS type stuff, couldn't walk, like weird stuff, was hospitalized, declining super rapidly. stop the bismuth, completely reversed.
But that's a known
That is a
toxicity
known-
of chronic bismuth.
Totally.
Yeah.
But because we talk about bismuth so much,
Right.
like
Don't
pulsing
keep
it,
people on it.
taking breaks, giving minerals with
Yeah.
it because it depletes minerals, just like don't
Totally good reminder.
be that person.
Totally
Right.
good reminder.
People will tank. Yeah.
Yeah. And that, I mean, that has been documented
Yep.
since the beginning of time.
Yep.
It's just, we don't think about it.
No.
And it's an OTC.
Well, you're also usually using it for like 6 to 12 weeks.
I
for
am
your
generally,
Yeah,
biome.
but 4 days on, 3 days off. So it's like pulsing.
I
it.
mean, that's not true with the hydrogen sulfide protocols.
True.
We're using
How
it
long?
straight, 3 months.
Oh, so 3 months. I mean, not 3 years.
Yeah, I will
don't-
generally, I like to take breaks.
Yeah.
Yeah, I don't do any more than 3 months.
Yeah.
And even then, if they're like smaller people, I'll do 2, take a break, go back on.
Yeah, and breaks, I think, clinically, for clinicians, it's a very important concept
Right.
because it's so easy when you're in the functional medicine space to be like, well, this supplement does this and this, and then all of a sudden your patients are on 60
Totally,
supplements, 80
totally.
supplements a day.
Yep.
80. That would be a new.
I have met
You've
that
had the record.
Oh no.
And my
Not
enti-
prescribed by you, prescribed
No,
by others.
my
people-
entire first patient, the first visit is like,
I
there's
know.
no way your
Can we
body
please
knows what to
stop?
do about this.
People come
Right.
in with boxes
Yeah.
full of supplements, and I'm just like, what? And it's easy. You have like one problem, supplement for that, another problem,
Yeah.
supplement for that. And then by the end of it, if no one's checking or you're doctor hopping,
Right.
I mean,
Or you're reading this online
exactly.
website, or you're getting this
Yeah.
Exactly.
magazine.
Marketing
like,
is powerful.
Powerful.
Yep.
And so what I will often do is I will often say, I think your supplements are poisoning you.
Yeah.
Okay.
Take a break.
So
okay,
look-
can we get to my questions?
Yes, go. I'm ready.
Okay, what are the types of microscopic
Okay,
colitis?
so there's 2 types. There's lymphocytic and collagenous.
Yep.
Collagenous has probably been there for longer, and it's definitely more difficult to treat
Why?
because there's literally collagenous foam. Like when they're biopsying it,
Gross.
the tissue looks collagenous. It's like
Gross.
definitely been
Say
inflamed
the
for
2
longer.
types again.
Lymphocytic and collagenous.
Okay.
So lymphocytic relates to lymphocytes being drawn to the inflammation.
They both are having lymphocytes drawn to the inflammation. 'cause
Okay.
It's microscopic inflammation.
Okay,
Is it,
so
like,
they're both
early in-
lymphocytic. One just has goopy goo.
Yeah.
on top.
Mm-hmm.
Does the
Gross.
one progress to the other?
Yes.
Okay.
Wow.
So lymphocytic is sort of earlier stage usually.
Lymphocytic is usually earlier stage. That you're more likely to find it if it hasn't been going on for forever in the lymphocytic state.
Huh. Okay, but same steroids for either.
Same treatment. I just don't think it's as responsive. And the
Totally.
collagenous will definitely take longer to deal with.
Do you see an association with the collagenous and biofilms?
I see an association with both in biofilms.
Yeah.
So what are my aces in the hole, right? What do I do that I think they get better
Yep.
when standard medicine stalls out? Whatever. Standard medicine doesn't really have any great
It works
options.
60 to 70% of the time though.
60
so-
70% of the time, totally.
Yeah.
It's amazing.
And then the rest of them
Always
come
start
to
there.
you.
Don't bother spending money on me if you haven't done a round of steroids to see if they work.
Yeah.
3 months, I'm not worried about your bones.
But here's the thing. Don't you think their microbiome has been disrupted
Oh,
anyway?
For
So
sure.
yeah, so steroids alone, like for prevention strategies and not having to rely on steroids, it's still probably worth seeing someone well
Yeah,
versed in
it
this.
still makes sense to, but even if the acute symptoms are resolved, if
Yeah.
you want to be more proactive about future potential
and
issues.
hopefully get to a more resilient platform
I
with
mean,
your gut.
So just so we're real damn clear, what are what do we think? What do we know causes this? Non-steroidal anti-inflammatories, SSRIs, statins,
Oh.
histamine receptor
really?
antagonists. Yeah.
Okay, there's evidence for statins and
Wait,
SSRIs.
Yes.
Antihistamines?
Yes.
Which ones?
Why?
H2 receptor antagonists.
Why?
Just the regular
That's what
over
they're
the
saying.
counter.
Mhm.
Why?
Okay, I think you need to say the list again.
Okay.
Yeah,
So
that just
so
blew my mind,
just
Okay,
too.
so-
this is like medications that a lot of people are
Yes.
on.
Totally.
Yes. So just so I'm being completely forthright, this is not in my brain. I'm reading this off of Up to Date right now.
Yep.
Could be in your
Up
brain
to Date. It could be in my brain.
also.
It's in
Right.
our brains now.
It would be amazing if it was. But I mean, how could I have space for that and for all the Excel spreadsheets?
It seems like
that I'm running?
SSRIs have a lot of side effects that I didn't initially know about, like the bone density issues as
Oh,
well.
yeah.
But anyway, go ahead.
Okay, so off of Up to Date, non-steroidal anti-inflammatories have been a causative agent to trigger a flare, and other drugs like proton pump inhibitors, specifically lansoprazole, statins, SSRIs, histamine H2 receptor agonists.
Wow.
Yep.
Wow.
I mean, like that list that I just listed. How much of America is on these medications?
A lot.
Everyone. And if it's causing inflammation in the bowels, what's happening in the rest of the body?
Word. I don't know if you guys have seen this article. There was this article like a couple of weeks ago on NPR or someplace, and they were basically like, colorectal cancer rising in younger and younger
Mhm.
populations. Medicine doesn't know why. And I'm like,
Yeah, plastics, toxins, drugs,
Yeah, I mean,
stress.
right. Like,
I could name a few reasons.
I mean, at this point, I think that we are
Nutrition.
probably a year or two away from setting the first screening colonoscopy at the age of 40.
I
Like,
know.
we just moved to 45. I think we need to move to 40.
I know. But remember, diet has nothing to do with this.
That's true.
Just kidding. Just
That's
kidding.
true. Okay, so pharmaceuticals will cause it, right? Pharmaceuticals will also treat it.
Yeah.
And yes, there's definitely a microbiome component, without a doubt.
Okay, so we do testing, microbiome. Second question,
Mhm.
ozone.
So ozone is one of my favorite treatments for this. I have seen it be very, very effective.
Rectal ozone.
Rectal ozone. So
Yep.
let me talk. We have
Are
to do.
there any US medical centers that use this?
Rectal ozone or ozone?
Yeah.
Like-
So actually
Conventional.
No. It's all the data's from
Why?
Europe, correct?
Lots of the data's from Russia. Lots
Okay.
of the data's from Latin America.
Okay.
There's some data coming out of Asia.
I don't understand why, because it works so well. It doesn't have money. Oh,
I mean, what's cheaper than ozone?
I know.
It's also like, I mean, also a lot of the ozone data is animal data. And so there's a little bit of a question mark there.
Yeah.
And then, I will also say the people who get really excited by ozone, they're not the people who I'm going to trust to do the most rigorous science.
Yeah.
Like,
But it works. It works for inflammation. Like the people I've kept off antibiotics with topical ozone, limb bags, like,
oh my God, limb bags. I wish. This is what I'm like.
For
I have
ulcers? For what?
for
No.
diabetic ulceration of
well,
the feet.
so
And
any
you,
skin
Rebecca?
stuff. So I had a patient who got like a terrible wound. It was like softball wound, but like gross thing on the knee. And I mean, it was looking bad. There wasn't streaking, like there weren't like warning signs, but we were nearing that. So like I had her get the antibiotics, hang on to them. And I was like, if I can get you in for a couple ozone, bag it, went away.
So can we
like completely healed.
Let's
Next
just do
episode.
an episode.
Yeah.
On ozone.
Okay.
Let's just do an episode on
But
ozone.
that patient had IBD and I wanted to keep her off antibiotics if we could keep her
Yeah.
safe and do that. And it worked. We kept her
Yeah.
off. So
And so ozone. So what are my aces in the hole? One, treating biofilms for sure. Two, rectal ozone for sure.
Yep.
After I've done that, and if the diarrhea is still there, high dose psyllium.
love
I mean,
psyllium.
High dose psyllium.
Yeah.
Like it's-
Anti-inflammatory. I love psyllium.
I had this one patient come in with the most effing intractable microscopic colitis. He was doing ozone because he read about me through one of Dr. Schallenberger's websites. Dr. Schallenberger is like the doc who teaches everybody ozone.
Yeah.
He learned about me through there. So he bought a rectal ozone. He was doing rectal
Amazing.
sepulation. Still, I could not get his diarrhea under control. I tried bismuth. I tried this. I tried treating, I tried it all.
So will bismuth in general do anything for microscopic colitis?
If there is, so oftentimes microscopic colitis is not the only thing that's happening.
Right.
And so, yes, bismuth.
If you're treating something else that bismuth,
Yep.
responds
bismuth
to.
will bind it. You know
Yeah.
what I mean?
So high dose psyllium.
High dose psyllium was the thing that we finally
So
got.
he did not respond to the steroids.
He didn't respond. And I made, he came in very hostile about the steroids. He'd been on them for 2 years.
Got it. Yeah.
He had seen his health pretty
understandable.
drastically decline.
Yeah.
Oh man.
That's understandable to
Right.
not want to keep taking it.
Right.
It's not working.
Totally.
So, psyllium.
Great.
And so then you're always going back to microbiome,
Mhm.
biofilms, and then you're the other thing you're going back to bulking up the fiber. Just bulk up the stool.
And if someone doesn't want to do steroids and it's not so horrible that they're, emaciated, you could potentially start with psyllium as an alternative
I feel like the reason why psyllium worked for him, and this is just my guess, the reason why psyllium worked for him is because he had done all the other things.
Okay. That makes
I
sense.
mean, he had like a beautiful diet. He was in ketosis 100% of the time. He high fiber, his microbiome, he had really worked very hard, which was making him crazy.
Right.
Because he's like, why am I working so hard?
Yeah, and it's not working.
And it's not working.
Yeah. So a little fiber boost.
Yep, and not a little.
Yeah.
A big old fiber boost, but it was what finally resolved it.
Yeah.
But then again, I have another patient who I saw this week, and I was like, okay, let's try this.
Mm-hmm.
Like, we've done a lot of work. Her underlying cause was actually fungal.
Yeah.
She had a huge fungal overgrowth that was causing her microscopic colitis.
Yep. Had she taken steroids previously?
I always have them I always have them take steroids.
So yes.
You want to know what else? Right now, the COVID that's circulating, that this exact moment in time, which we're recording this on
March
2024. Something. Yeah, the middle of March 2024. it's a very GI based strain, right? Like it's very, very little upper respiratory
compared to the last
mainly
ones.
It's all GI.
Yeah.
And I have had, like dominoes, all of these patients that have been so damn stable get a very mild COVID with a side of diarrhea that never goes away. So that's what I'm trying to clean up right now. And I'm trying a bunch of protocols to clean, like all of the things that usually clean it up. I'm trying it now
Psyllium?
to see psyllium, glutamine, immunoglobulins, like all of those things that we do, probiotic, like all those things that we do. That's what I'm trying right now.
Resveratrol?
Resveratrol causes diarrhea.
Yeah, the high dose. Yep.
So I have not tried resveratrol.
Yeah. Lowers DHEA.
Does it?
Yeah.
Resveratrol?
It's my new favorite. Yep.
You've seen it?
Yeah, and we have studies on it, or at least one study.
Ooh, cool. I don't have anything.
When we get to our PCOS episode.
So just so everybody knows, we've been talking about the PCOS series that we're going to do.
For like a year and a half.
I think since we launched.
Yeah,
it was
that's really true.
First list of episodes.
Yeah, well, that'll probably be a 3-parter.
Okay, any other questions on microscopic colitis?
I think we're good.
I think we're good.
Yeah, that was awesome.
Anybody want to do a quick recap?
Yeah, so okay, we got to get diagnosed. Only way, colonoscopy with biopsy. Then we pound them with steroids, and then they come to us. Or you, fellow turd nerds out there. Do some microbiome testing, figure out what kind of co-infections, other stuff that's going on that's leading the microbiome to be a little unstable in these folks. Treat it, give them some resilience. If all else fails, psyllium and ozone.
Okay.
Thanks for tuning in.
Thanks for joining us today. Stay tuned. We release episodes every 2 weeks.
If you like this episode, please subscribe and don't forget to rate and review us to help spread the turd nerd word.